A very beautiful morning to you. Thank you so much for tuning in and joining us this amazing Tuesday morning, the 13th day in the month of October 2024. All right, it's about 5 minutes after 10. Are you feeling the love in the air? Of course. I mean, it's a season of love. It's a period of love. So you need to share it. Whether you don't have love inside your heart, go and look for it and share it. Okay, just look for it and share. I mean, it's when the season of love right now, so everything should be all lovey-dovey. Yeah, even if it isn't, just pretend to be. And you know, so what they say about pretend sometimes actually keeps you in that mood. All right, and you just find yourself going with that, flowing with that, and it might just come true for you. All right, so well, this is Women Radio WFM 91.7, which is Nigeria's first radio station for women and their families. My name is Rose Yusuf Kaiser, and of course you're welcome to Radio Doctor right here on Women Radio WFM 91.7. Radio Doctor is your free health consultation program where real doctors advise real people. Radio Doctor is Nigeria's first specialized health program where medical doctors consult for free and advise right here on Women Radio. All right, and it comes to you Mondays through Fridays from 10 a.m. So today on Radio Doctor is on women's health. Like you know, we have different days of the week for different specialties. Yesterday we started up with children's health. Today, of course, we are on women's health. Tomorrow is going to be on general health, of course. All right, so today's women's health on Radio Doctor is supported by ACT Foundation. All right, so once again, my name is Rose Yusuf Kaiser, and our radio doctor for today is Dr. Collins Abolaje, and he's an assistant medical director and fertility physician at St. Ives Specialist Hospital. Good morning, Dr. Abolaje. How are you? Are you feeling the love in the air at all?
Good morning, Rose. What can I actually say? Well, I think I would say yes and a little bit of no also. Yes, being that yes, it is a period that we all get to celebrate, you know, even for those people that are not in relationships. It's not about just being in a relationship. It's also about just spreading love to one another, to your colleagues, to people around you, your neighbors, and of course to your family members. And however, for saying no, I am actually referring to people who actually have endometriosis, who, of course, this season will not be showing love to because of the severity of the symptoms or the severity of the condition that they may be having, that they are having, okay, and how, of course, it affects their quality of life.
That's true. Now, mentioning that, just, you know, it just faded a little smile from my face this morning, but it's all good.
I'm so sorry I did that. Honestly, but I understand. The moment you were talking about spreading of love, I thought I just had a broad overview of what love should actually be and what it should mean. And of course, I did a little bit of a reference to our topic, and I saw that, of course, these guys will not be experiencing much loving because, of course, they actually experience a lot of things, both psychologically and physically.
True. And that's why it's actually important that you spread the love, okay? If you have enough to go around, just share it around, because you never can tell what somebody's going through. You never can tell what the woman next to you is going through. We go through a lot as women. We go through a lot. Well, it's all good. At the end of the day, it's all part of life, and we'll overcome it. We'll definitely overcome it. I mean, it will overcome it. All right. Thank you so much, Dr. Collins Abolaje. It's so good to hear from you this week, and I'm super excited for the topic that we're about to treat, because the sad part of it is that a lot of women don't even know that this is what it is. They don't even know. They don't have the slightest idea of what's going on with them. But they keep getting the signs, they keep seeing the symptoms, but you know, it's not just, their minds don't go there. And unfortunately, there are some medical practitioners that don't even know what this is. All right, they're not even sure where this is coming from, what this is. So I mean, it's good that we have the appropriate information this morning. All right, so yes, this is Radio Doctor on Women Radio WFM 91.7, and of course it's 9 minutes after 10 right here on the program, your free health consultation program where real doctors advise real people. So you've heard Dr. Abolaje talk on endometriosis, because that's what we are going to be talking about today. That's what Dr. Abolaje will be consulting and advising on. All right, let's not forget that Women's Health on Radio Doctor is supported by ACT Foundation. So we're looking at endometriosis. We're going to know what this is. We're going to know all about endometriosis, how it comes, how it goes, how we can manage this, all that has to do with it. I mean, that's why we have Dr. Boloje with us this morning. So our phone lines are open, of course. Do well to call in via the number 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. You can go ahead, of course, follow us on our social media platforms: Facebook, Instagram, X, and of course YouTube at WFM 917. And you can go ahead and log on to our website www.wfm917.com. All right, so let's head on straight to what we have today: endometriosis with Dr. Collins Boloje. Okay, so this is Women Radio, just in case you are joining us for the first time. All right, Dr. Collins, let's head on straight with it. Let's start from the foundation of it. Yeah, let's just start from the very foundation, because if we don't understand what this is, then any other thing we're talking about would just be like building castles in the air for people. So let's have an overview. Just give us a foundation of what endometriosis is. Let's just know that first of all.
Okay, so let me give a very background. I want to give a foundation, like from the lowest step of it, and this, of course, would commence this discussion from the anatomy of the womb itself. The womb of a woman, otherwise called the uterus, okay, has three portions to it. Okay, it has the outer portion called the perimetrum, and then it has the middle portion called the myometrum, which is a muscular layer. And then it has the inner portion called the endometrium. That endometrium is a layer that bleeds every month, and it's also the layer where a baby implants, where the embryo implants and grows into a full-blown baby. Okay, so that endometrium of the womb, okay, or of the uterus, okay, that endometrium has two layers. It has the basal layer, and it has the functional layer. Okay. The basal layer is what gives rise to the functional layer. Okay. So the functional layer is the part that bleeds every month, that sheds, and it grows thick in the first half of the menstrual cycle. Once the woman ovulates, if that egg that is released does not get fertilized, of course, progesterone starts to be produced, okay, from that follicle that ovulated, and of course, will prepare the woman to see another menses within a couple of days. Okay, so that functional layer is the layer that sheds, that breaks down to release blood, okay, which of course is called the menstruum or the menstrual bleed. Okay, so endometriosis is a chronic disease, okay, that is characterized by the presence of that endometrial layer, the presence of that endometrial tissue, the tissues that are present, that are supposed to be present only inside of that endometrium, which is that inner layer of the womb. They should be present only in that space. They are not present in areas that they're not supposed to be. When you find this tissue present in maybe on the bladder or on the rectum, on the pelvic organs, on the peritoneum generally, this condition will now be called endometriosis. So it is easy for our medical practitioners to understand this definition, but with respect to the general public, they might find it a little bit challenging. But let me just go over it again. It's simply a chronic disease that is characterized by the presence of endometrial tissue, a tissue that is supposed to be present only inside of the womb. It is now present on the outside of the womb or outside of the pelvic cavity in the abdomen. Okay, so because of this, what happens is that usually for women who have endometriosis, I'll just give a little bit of digression here. For women who have endometriosis, sometimes, okay, what happens is that when they bleed, when they see their menses, the tissue, those endometrial tissue that are outside the womb, would also be bleeding. So on some occasions, you find women who have these endometrial tissue that are present within their lungs. They will be coughing out blood when they see when they are seeing their menses.
Wow.
It can really be terrible. While for other women, you see them, because of the deposition of this endometrial tissue on the bladder or in the rectum, whenever they are seeing their menses, they will also be passing out blood in the urine or passing out blood in their stool. Or for some people, when they're about to see their menses, it becomes like a tug of war, becomes like World War III, where they have serious pain because of the presence of this endometrial tissue on the ligaments that holds the uterus in place inside of the pelvic cavity. And for some other people, you find this endometrial tissue also present within the muscle of the womb itself. Like I said earlier, that endometrium as endometrial tissues, and these tissues should not be found elsewhere. They should only be present inside of that endometrium. So for people having endometriosis and different forms of it, like I explained just now, okay, you can also find some other persons that have this endometrial tissue in the muscle of the womb, and usually we call this internal endometriosis. We call that, it simply means adenomyosis. Some people might have heard it, might have seen it online. Okay, this is what internal endometriosis simply means. It's a different topic on its own, so I'm not going to dive into that today. We'll be talking generally on basically on endometriosis and the general overview of it. It is stated that around 10 to 15% of women of reproductive age actually suffer from this disease. And in Nigeria, we found out that almost 40% of women who go over to the hospital to complain of dysmenorrhea, that is pain during menses, okay, and pain generally, maybe during intercourse and all, they actually have endometriosis. Yes, on the first hand, usually we'll be suspecting pelvic inflammatory disease, but on the second hand, okay, it is actually endometriosis. This is what studies have actually shown. So for people who don't know what reproductive age means, it simply means a woman who is between the ages of 15 and 49 years of age. So it's stated that around 10 to 50% of women who fall into this category actually are suffering from endometriosis. And almost 50% of women who have endometriosis will ultimately suffer from infertility, will definitely have infertility. Now, the reason is because this disease is actually has different ways in which it manifests. Okay? Just like we said, it could cause infertility in some people and could cause some other complications like pelvic adhesions and the rest. Of course, we'll go into that in the course of this discussion. It is a hormonally dependent disease, meaning that it depends. It's more like it feeds, it thrives, it progresses on the supply of estrogen. Estrogen is the hormone that is present inside of the woman. Usually there are two hormones that would that actually play a vital role in helping the woman to see menses. Okay, estrogens and progesterones. So endometriosis is an estrogen dependent disease. So it usually thrives on the presence and the availability of estrogen inside of the woman. So what this means is that as long as the woman keeps seeing menses, the disease will continue to progress. Same way it happens in people who have fibroids. As long as they keep seeing menses, the fibroids continue to grow big. But now, with respect to endometriosis, same thing also applies. It usually has different classifications. Okay, depending on the location. Like I said, it can also be present on the ovaries, it can be present on the pelvic cavity, it can be present on the peritoneum. The peritoneum is simply the lining. There's a lining that is present inside of the body of everybody, of humans generally. Okay, in the abdominal cavity, there's a peritoneal cavity. It's like a wall. It's like a what would I call it? It's like a tissue, or like, maybe permit me to use the word, like a veil, or like a curtain that's just spread in the inner portion of the abdomen and also lines the pelvic cavity also. Okay, so for some people, this endometriosis, this endometrial tissue will be found on this peritoneum. For other people, it can also be found on their bladder, on their rectum, in the lungs. In some people, strange, but yes, it exists. It is deposited on the lungs, and then of course can also be found on the muscles. Okay, on the muscles of the womb itself. So these are some of these expressions. And then for some other people, it can also be classified, okay, for them, depending on the expression of disease in them. It can either be superficial or deep. And for others, depending on the implants that are present, it can either actually be an implant, a nodule, or a cyst. It can actually express itself as a cyst, where some people, when they go back to the hospital, the doctor is telling them, madam, you have what we call an endometriotic cyst, or others call it chocolate cyst, or we call it an endometrioma, usually present on the ovaries. And yes, it can really be that serious. it can really be that. So according to the Association of the American Society of Reproductive Medicine, usually they grade it, they classify it into 4 degrees. It can be minimal, it can be mild, it can be moderate, and it can be severe. And these also translate to the stages of the disease. So for some people, you can say it's stage 1, stage 2, stage 3, stage 4. That is simply what I just talked about. You can also call it grade 1, grade 2, grade 3, grade 4. You can call it minimal, mild, moderate, and severe. Depending on the severity of the disease or the staging of the disease, of course, there will be associated management and associated recommendations for people with respect to getting pregnant and respect to their fertility.
Okay. Thank you so much, Dr. Apology. Honestly, this is really deep. And funny enough, I've been hearing endometriosis, but a good explanation like this, I don't think I've, ever gotten to hear a very deep analysis on this. Thank you so much, Dr. Apology. This is Women Radio FM 91.7, 20 minutes after 10, right here on Women Radio. And of course, this is the program, Radio Doctor, your free health consultation program, where real doctors advise real people. So yes, this is Radio Doctor, and Radio Doctor is for you. So do well to call in. Let's get your thoughts, your concerns, your questions on endometriosis today, because we have Dr. Apology to answer to your concerns, your questions, and of course your thoughts too. 07000 917 917 is a number to call. Send us a text or a WhatsApp message to 070 317 56537. That is a number to get in touch with us this morning on the program Radio Doctor. Today is on women's health, hence we're looking at endometriosis, and of course women's health on Radio Doctor is supported by ACTS Foundation. So feel free to call in on 07000 917 917. All right, Dr. Apology has given us, an overview, in fact, a very good foundation on endometriosis, all right, and he has taken us all through, like, all we need to know. Yes, I know that maybe some words might not be familiar to you, but I'm sure that at the end of the day, you get it, okay? Because we should be armed with the right information. If we need to deal with something, then we need to know where it is coming from. We need to know how, to actually go about dealing with this. All right, so now, I think what most of us will really want to know, which I know you've touched a little, but let's just dwell on this, Dr. Apology. How does endometriosis affect fertility, and what specific challenges would women face in trying to conceive with this condition? Because ultimately, most times, that is where you get to know what is going on. Once a woman is, okay, yes, I think I'm ready now to have a baby, or after marriage, you want to have a baby, and then you start, there are delays here and there, and you go for some investigation, and that's where you begin to know, oh, this is why you're having this is why, and then you start tracing back to when you started noticing some of these things without taking any action. So I think ultimately this is, what we really, really, really want to know. How does this, you've touched on it, but let's dwell on it a little bit, Dr. Apology, because this concerns a lot of women, this concerns in a lot of families too. How does this affect fertility? All right, and let's look at the challenges that women will face in trying to conceive with this condition. All right, and let's see, because you've also talked about some signs, you've talked about some symptoms too, of this endometriosis. So, but let's dwell on this for a bit.
On this, okay. All right. So, before I proceed to that, I will just simply talk about the symptoms. I knew the question was coming anyway. So, basically, one of the commonest symptoms to experience when a woman is having endometriosis is painful menstruation. I mean painful. When I mean pain, in fact, the pain has a capital letter P. This is me just trying to be, yes, honestly, it is really terrible. As a matter of fact, let me just digress a little bit. I actually have a friend the sister to a friend of mine who has this same endometriosis. And this is the reason why the moment you talked about spreading of love, it just brought that girl to my mind. Because we've been on this case for a while, and it is really terrible. In that sometimes she calls you crying and telling you that who would marry her with this condition, because to have intercourse itself is World War III. It is painful. painful. We usually call it dyspareunia. And then to see the menses itself, when the menses is about coming, even before the flow starts, she's in serious pains, cramping like hell every day before the menses starts. And then the next thing, when the menses now starts itself, throughout the bleeding, usually for people who have dysmenorrhea or painful menses, they usually will experience it maybe the first 1 or 2 days, and then it subsides as the menses also withers off, but for them, for people with endometriosis, the pain usually will just be present throughout the entire bleeding phase. And to add to this, sometimes they even bleed longer than expected. You find people bleeding even more than, for some other people on the average, you find people bleeding between 3 to 5 days. For theirs, they could bleed beyond 5 days, even up to 7 days, and there will be pains all through, And of course, with the associated other symptoms like low back pain, passing of blood during urination or even during stooling, and of course the psychological symptoms that also are associated with it, like depression. Talking about the other lady now that always would tell you that who would marry her like this, she's always depressed when it comes to trying to see her menses. When it's time for her to see her menses, she's depressed. She's just of low mood, masked with it, overwhelmed with low mood. So these are some of the symptoms. So if anybody's experiencing all of these, of course, they also want to try to get evaluated to check all of that. Now, to speak about how it actually affects infertility, for some people, they will tell you that endometriosis usually has 2 Ds and 1 I. Okay, it's usually what we just use to just give people to be able to remember a lot. It has dyspareunia, dysmenorrhea, which I just spoke about, and that is painful intercourse and painful menstruation, and of course, it has infertility in there. Now, endometriosis causes infertility through 3 mechanisms generally. It affects the transport, of the egg generally, or it affects what we usually call it uterotubal transport, impairment or interference of uterotubal transport. What this means is that, generally when a woman ovulates, the egg comes into the tube. Okay, so what this endometriosis does is that when these implants, this deposition of this endometrial tissue are found, sometimes, like I said, it shouldn't be present elsewhere except inside of the womb. But in this case, it will be found inside of the tube. The tube should be a free passage, lined with other cells, ciliated cells, and ciliated epithelium that will allow the movement of egg. But in this case, when that endometriosis is deposited inside of the tube, it will prevent the sperm from meeting with the egg, just like the way adhesions or even the the normal tuber blockage will prevent the meeting of the egg and the sperm. That is one mechanism. That is one way through which it causes infertility in people. Another way is that it will also express itself as cysts within the ovaries. These cysts are not your classical cysts. They are not your simple cysts. They are actually cysts that are made up of altered blood present within, because as the woman keeps seeing menses, those tissues that are present within the ovaries will also bleed. And as a result of that, there will be cystic formation, of course, in the ovaries. And this cyst will also help to reduce the ovarian reserve. So for some women, because of the size of the cyst itself, it will prevent that ovary from ovulating. So that's another mechanism. The presence of these ovaries can also cause adhesions that ultimately would also prevent the movement of the egg from the tube, from the ovaries into the tube. It will cause adhesions that can link, that will connect the ovaries itself to the pelvic wall in an abnormal way. Okay, so this is one way. So that's the affectation of uterotubal transplant. The next thing is that it also prevents the woman's the endometrium itself, that inside of the womb, from being fertile through a cascade of inflammatory events, which of course I won't dive into because that will just eat part of our time. Okay, and then the last thing is that it also impairs implantation. Usually, when a woman ovulates and the egg is produced from the ovaries, okay, after it gets fertilized, the egg becomes an embryo. That embryo is supposed to move into the endometrium, inside space of the womb now, to implant, just like you would put a seed into the soil and cover it. So same thing should happen, okay, to that embryo. So when it moves into that endometrium, okay, the environment already inside of that endometrium, because of this endometriosis, will be embryotoxic. There are substances that are being produced that will kill the embryos, or that would also make that endometrium itself to be non-fertile. There are certain substances that should express, that should be available when in a phase we call the endometrial receptivity window. okay, or endometrial receptivity. That's a term. Okay, it means a particular time period where the endometrium is welcoming, the womb welcomes an embryo. But what this endometriosis does is that it helps it to be unwelcoming to and very hostile to any embryo or even the egg far off in the ovaries. Okay, so these are the ways it also affects and prevents people from getting pregnant. But in all of these, they are still subject to the degree or to the grading of the disease. For people who are grade 1 and grade 2, these are still the mild or the minimal or the mild degree or stage of the disease. They can still get pregnant naturally, okay? But it will be harder for people who have the grade 3 and grade 4, which are the severe stages of the disease, where there are presence of cysts and all, large cysts and adhesions, tying, holding the womb in an unusual way, shifting things, tying the tube, connecting the tube to the wall, just causing problems because of that unusual attachment, hanging of, there will just be some unusual, we call them adhesions, okay? So they are adhering, they are holding the organs in an unusual fashion to the walls, or maybe attaching one tube to the ovary together. If you have seen adhesions, usually they are like fibrotic tissue. And if you have ever opened, there's something we used to call a vo stick while growing up. I don't know if it's still available. It's like a chew gum. There's a way it looks when you draw it, when you take a portion of it out of the container that it comes in. It has this stringy, it has this like fibers. They look like fibers. So these are the ways adhesions actually manifest themselves. So they will hold structures in an unusual way, attaching them in the places they're not supposed to attach themselves, or tied together. And so because of this kind of unusual attachment and unusual relationship, usually this can prevent a woman from getting pregnant, because the eggs truly will not be able to move down the right path to meet with a sperm. And so the woman experiences experiences infertility.
All right, thank you so much, Dr. Bolaji, for this. But wait, Dr. Bolaji, just 1 minute.
Yeah.
What will make these tissues live where it's supposed to be and develop in other parts? Because from all your explanations, you said we could have this tissue on the womb, we could have it on on the bladder, on different parts of a woman's organs. So what will make it want to leave that section where it's supposed to be, okay, and just go and
move over
and start creating havoc and just making a woman go through a lot?
Yeah, so actually the cause of this disease, okay, is still unknown, but usually in medicine, when we are always, as scientists, usually we are very, very, very stubborn. So we don't want to settle for the fact that the cause of a disease is unknown. We would always look for a theory. We will always be able to tie the existence of that disease to a particular reason, to a particular mechanism. Number one is what we call retrograde menstruation. Retrograde menstruation. Now, when a woman sees her menses, the menses flows down. It flows out through the vagina. Yeah. But in this case, they have attributed that the reason why this endometriosis is present in some women is that they see their menses and there has been movement of that menstrual fluid, that menstruum, okay, the blood, through the tubes and into the wall of the tummy, into the wall of the pelvic cavity. I'm trying to use a word that people can easily relate with. Okay, so that is one. It's called retrograde menstruation. Okay, it doesn't happen in everybody, but it happens in some other people because of adhesions. And usually they have attributed this endometriosis to retrograde menstruation. For the next people, it could be that there is being what we call a metaplastic theory. Metaplastic theory simply means that because of genetics and because of environmental changes and environmental factors generally, the tissues, normal tissues, have transformed themselves into endometrial tissue. So that means this second theory is saying that there is no retrograde menstruation. There's no movement of the blood through the womb and into the pelvic cavity, but that it is the transformation of the tissues, maybe the tissues of the bladder, will just ultimately transform by themselves, okay, into endometrial tissue. For some others, they have also talked about a theory which we call the vascular theory, where during menstruation, some fragments of this endometrium, because usually that menstrual blood, fluid or menstrual bleed usually contains some of the endometrial cells and all of these things. It is said that some of these tissues have been transferred from inside of the womb through blood supply or through the lymphatics, okay, into distant areas. And for some other people, they are also on the side, they're also advocating for what we call the immunological theory, which of course says that there's inability of the female body to destroy endometrial implants whenever they find themselves outside of the cavity. So you can see in all of this, it will still be difficult for most people to understand it. But as medical practitioners, we have been able to settle for one or some or even all of these theories, because it seems to be the only reasonable reason. Now, permit me to use that word, reasonable reason, okay, as to why this endometrial tissue should be found elsewhere besides the inside of the womb, besides that endometrium. So I hope I've been able to clear some of those.
Oh, yes, because that question has just been ringing in my mind. I'm like, okay, so... Oh, anyway, it's all good. Thank you very much for this, Dr. Bolaji. Do want to call in on 07000 917 917. Let's get your thoughts, your concerns, and your questions too on the topic of discourse today with Dr. Abolaje. So do want to call us on 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. All right, so those are the numbers to get in touch with us this morning on the program Radio Doctor, your free health consultation program, where real doctors advise real people. And go ahead to send us your questions too, so that we will be able to take all of it this morning. All right, so we have a question here, but it's something that you just answered. All right, this one, there's no name to this, but she says, please, what causes it to start growing outside the endometrium, which you just answered? And because that's the same question that's the same question I asked. I'm sure that's what will, ring in so many people's mind. Like, okay, you're supposed to be here, so what's making you to grow outside where you're supposed to grow?
Somewhere else.
So thank you very much for answering that. You can also send in your own questions on 070-317 56537 as a text or a WhatsApp message. All right, Dr. Bolaji, let's head on to discuss more on this before our time is up on the program. So now we've been able to know what this is. We've been able to understand how it affects fertility and how women get to, women who are trying to conceive, how it gets to affect them, and all of that. So does this have anything to do with lifestyle changes? Does it have anything to do with our lifestyle at all, or is something that happens that we probably cannot control? It just maybe happens to some women, like you gave us statistics earlier. Is it something we can control?
Actually, it doesn't have any direct relationship to the lifestyle of the woman, okay, or it is just that basically what we are saying is that there are some risk factors to this. Okay. Just making reference to the statement I made earlier, generally as scientists, they usually would want to tie, just to help us study it better. So basically we've seen that there is really no lifestyle changes, okay, that would affect it. It's not something that is present in your diet or that is causing it, or, it is just some people just have this propensity to develop it with respect to these risk factors that I'm about to talk on. Okay, first of all, for a woman who sees her menses very early, for some women who see their menses, of course, before the age of 13 years of age, usually, or maybe around 12, 11, 10, usually these people, they have this, they are said to have a high risk to develop this endometriosis. For people who see their menses longer, who bleed for days, days that are longer than they expected, beyond 3 to 7 days. For some people who bleed, whose menstrual bleed would extend beyond 7 days. Usually, these people are at high risk of having endometriosis. People who have had surgeries before, cesarean section, dilatation, and curettage. All of these people are also at high risk of developing endometriosis. And of course, people who have never even given birth before, people who have never gotten pregnant before. For some other women also, maybe young ladies who maybe they have what we call imperforate hymen. So maybe at the time when they were supposed to see their menses, they were not seeing their menses. So the fluid, the menstrual fluid keeps accumulating inside of the womb and not coming out. Okay, so that is a different condition in itself. It's called imperforate hymen, where for women, they have hymen, okay, that covers the opening of the vagina, okay? So basically, for some of those women, theirs is imperforate. It is like a membrane completely closing the vagina. So as at the time they're supposed to see menses, they wouldn't see menses, and that would be cause of secondary amenorrhea for them, because they actually see menses, but it's just that the fluid is not flowing out. It is just being collected inside of the womb. So that predisposes them to also having endometriosis in the future. Now, mind you, all of these are just risk factors, and their postulations and theories and all of that. Okay, and of course, lastly, for women who have a first degree relative, okay, that had the endometriosis, maybe having a sister or a mother that had endometriosis, also predisposes women to having endometriosis. But with respect to lifestyle itself, is it your smoking? There is no relationship between that, between smoking and endometriosis, or between lack of exercises and endometriosis. No, there's all of those relationships. There's no study that has shown that, at least none that I know of. But the ones that I know of and the ones that are rightfully out there are the ones I just listed, and these are the risk factors.
Okay. All right. Thank you so much. So let's head on to look at the treatment. What are some of the treatments available for this?
Okay, so now before we just head on to the treatment, we would of course have to diagnose the condition. So basically, some of the criteria for diagnosis simply involves one, using the symptoms, expressing the symptoms that the patient is expressing to you. Of course, in fact, the moment you tell a doctor, that is a doctor in the field of fertility medicine or a gynecologist, basically they would the moment you're telling them that you're having painful menses and painful intercourse, their mind would not only go possibly that the lady is having a pelvic inflammatory disease, but the next thing that will be on their mind is endometriosis. It is just a very, it is like a, how will I call it now? It's like a no-brainer for a doctor. The moment you're saying, I'm having serious pains, even for a young lady, 26, regardless of the age, the moment you start talking about that, they're all, of course, thinking about endometriosis. So so basically we use the symptoms. Number two, we would use, of course, transvaginal scan, okay, transvaginal ultrasound to diagnose endometriosis. Now, we can only use this to diagnose a particular type of the endometriosis, which is the cyst, which is the endometriotic cyst, because when you do the scan, you see a characteristic cyst with ground glass appearance in the ovaries. So you're able to actually detect that, okay, yes, this lady actually has endometriosis. And then, of course, MRI has been used to diagnose endometriosis. And lastly, which is the gold standard to diagnose endometriosis, is laparoscopy. We have to pass a camera. It's like a telescope. We call it a telescope, but it's passed into the tummy. Okay, it's actually done under sedation any which way. So basically, the lady is sedated and the tummy will be inflated, and then the camera is passed in there, and then to visually inspect the pelvic cavity and to see the presence of these endometrial implants on different structures of the pelvic cavity. And then when you do that, you're able to see that, okay, yes, these endometrial implants are present on the ligaments holding the ovary, holding the womb in place, or they are present on the bladder, present in the pouch of Douglas, present in different structures in the pelvic cavity. So that is the gold standard for diagnosing endometriosis. Of course, tumor markers can be used, but these are very, very non-specific, because some of these same tumor markers like CA125, okay, they are also going to be present in people that have ovarian tumors, also present in people that have some other gynecological conditions. So basically, these are non-specific. The gold standard for diagnosis is laparoscopy.
All right. Thank you so much, Dr. Aboloje, for that, for giving us the treatments available for endometriosis. All right. This is Women Radio WFM 91.7. And of course, you can call in via the number 07000 917 917. All right. So go ahead. You wanted to say something, Doctor?
Yes. Yeah. I wanted to say something. Okay, so talking about the treatment, I think I want to just dwell on the diagnosis.
Okay.
Yes. So let me just quickly talk about the treatment. So talking about the treatment generally, when we talk about the treatment of endometriosis, we use certain factors in determining how the treatment of this patient would go. First of all, we use the age of the patient. We use the symptoms that the person is experiencing, which is talking about the quality of life of the patient. So we also have to factor that in as a part of the treatment decision, and of course the desire to get pregnant. So basically, when we talk about the treatment, now after all of those factors have been discussed and highlighted, okay, we'll now have to talk about the use of medications. Generally, we want to treat the symptoms, whatever, irrespective of the age of the patient. You want to treat the symptoms, the pain during menses, the painful intercourse and all, and the heavy bleedings during menstruation has to be treated. And of course, we use medications like analgesic medications. Okay, we like ibuprofen, mefenamic acid, tranexamic acid. These are drugs that are actually used to actually help to take care of the pain that the woman would experience during menses. And of course, talking about the heavy bleeding, we use medications like the combined oral contraceptives. There's a reason why you use them, because they're able to actually take care of the bleeding and also take care of the pain that is being produced. Of course, we want to use drugs that contain progesterone. You know, earlier I said this disease is actually estrogen dependent. So basically, you don't want to give anything that has you don't want to give estrogen medications, because you would only be fueling. It's just like pouring fuel into a small fire somewhere. You know, of course, you're going to ignite and of course increase the intensity of that fire. So basically, you don't want to give any medications that would have a very high level of estrogen. So basically, this statement actually favors now the use of progesterone medications, progesterone only pills, okay, where they are given over a period of time. And the reason why you give them is also, of course, to also control the bleeding and of course also control the pain for the woman. So it helps to make the inside of the womb to become, we usually call it endometrial atrophy. So it helps to make the inside of the womb to be thinned out. And as a result of this, okay, the woman would not even see menses the way she should. And as a result, it will also help to reduce symptoms, all the pains and all of that, the heavy bleedings. Because if the woman is not seeing menses, okay, so of course she will not have the pain. You not have the dysmenorrhea and of course the heavy bleedings. And again, we also use drugs like the GnRH agonists. They're actually meant to, of course, alleviate pain and of course the bleeding, and also help the woman generally, help her quality of life. Surgery has also been advocated for, where those implants are removed. Okay, they are actually laparoscopic surgeries where those implants will be removed so as to help the woman, so as to reduce all the pain and of course help her quality of life. Hysterectomy is also the one way to completely eliminate this endometriosis, to remove the uterus, because as far as the woman is not seeing menses, or remove the uterus and of course the other structures that are present within. As far as the woman is not seeing menses, of course she won't have all these complaints. But as far as she will still see menses, which is of course going to be propagated by the presence of estrogens and all the whatnots, she would continue to have complaints. So, and for people who fall within a specific age range, especially for people who are under the age of 35 and are still desirous of having a baby, okay, they can still get pregnant, okay, through assisted procedures like the intrauterine insemination, IUI, especially for women who are under the age of 35. But for women who are above the age of 35, usually would advocate and are having and are also having a higher grade of the disease, especially grade 3 and grade 4. Usually we tell them to go in straight for IVF without wasting much time. But like I said, if a woman is under the age of 35 and is having a low grade of the disease, grade 1 and grade 2, they can still do IUI. But of course, not for long, like you would do to somebody who does not have endometriosis. The moment you do it just once and it doesn't work, you actually want to step up the treatment, because there is no time. Their eggs are reducing, especially because of the presence of cysts that will be present in the ovaries. So you don't want to waste time trying some other fertility treatment. You want to actually hit the nail on the head as soon as possible to help them. For some other people, because endometriosis also affects egg quality, okay, they may also resort to the use of egg donation for their IVF treatment. And for others, especially for women who have very large cysts in the ovaries that have occupied the entire ovaries, and there is already diminished ovarian reserve, the absence of viable antral follicles, of course, these people might also resort to, having, like I said, egg donation, or even for some other people, because of the severity of the disease, they might also end up having to do surrogacy. Yes, because of this a severe stage of the disease, grade 4, with so much adhesions and a frozen pelvis, this might actually be the reason why they would have to have somebody help them carry pregnancy, surrogacy, or to even go outrightly for adoption. These are some of the options. So IUI, IVF, egg donation, IVF, surrogacy, even egg freezing, okay, is also another viable option. Egg freezing is actually allotted to people, okay, who are still very, very young when they diagnose them with the disease. So they basically want to freeze their eggs when they can, while they still can, so because the disease would always continue to progress, like I said, as long as the woman keeps seeing menses. So the earlier she freezes her eggs, the better, so that even if it progresses to a stage where she no longer even has quality eggs or no longer has eggs anymore because of the disease progression, she still has eggs present in the egg bank.
All right, thank you so much for giving us all of those treatment options, and letting us know that there are definitely options for when you are maybe ready to be a mom or ready to be parents with this. I'm sure that these are different ways that you can get to achieve it. So that's just to say that it is not the end for you, to have this, because I'm sure that doctor has seen cases of women who have come to him with endometriosis and have been able to find a way to have their own kids. Am I right, doctor?
Yes, you're right.
Okay, so that's to say that just calm down, relax, and of course everything will be fine. So as regards to the pain, during a menstrual period, for a woman with endometriosis, are there options that could help relieve these pains? Are there, and how long would she continue to have this pain till probably something is done, maybe like the surgery or something of that nature? I'm just talking because for one without endometriosis, sometimes the kind of cramps that you get could just knock you off, all right, let alone a woman with endometriosis. So is there something that could actually help relieve the pain all through maybe for the years that she might be still having the menstrual flow? Because I can just imagine how every month will become like you're dreading that particular time of the month. So it's almost as if before the next period you just have maybe a few days window just to be yourself, and before you know, you're already back to the same pain again. So I'm just imagining what a lot of women go through. So what's the available option to help at least a lady live a normal life, with this?
Okay, so basically, the answer to this question still lies in the fact that as long as a woman keeps seeing menses, she would go through all these symptoms, serious pains. But, there are medications to help her, some of which may even prevent her from seeing menses, which will now be, of course, a little bit of respite for her and a little bit of enjoyment period or free period. Sorry, I beg your pardon. I don't want to have to use that word enjoyment because this is not something funny, it's not a funny condition at all. It's not funny at all. So basically, she can use medications while she's seeing menses. Okay, they can also help, but the degree to which they can help is also limited. Okay, when you use medications like ibuprofen, they also help to reduce the synthesis of certain substances like prostaglandin, which is of course, which is what really causes the pain in women during having endometriosis, or even women that usually have menstrual pain. So you use medications that will stop that production. Okay, at least for that time being, for that period while they are seeing menses. Drugs like ibuprofen, mefenamic acid, tranexamic acid. Okay, also still help them to still, while they are taking it, they can still be having normal ovarian function. But for some other drugs like having contraceptives, progesterone only pills and all, these are contraceptive medications. Okay, so what they help to do They will help to prevent the woman from ovulating and also make the womb to be pain. So as a result, the woman may not even see menses even while taking them, depending on how she's prescribed the medication. And for some of these medications, they would have to take it for between 3 to 6 months for them to have just to have that space to be symptom free for that period. So when they remove those medications again, the entire cycle of pain and all of that starts. Okay, so that is the only drawback with using contraceptive medications. So while you're on it, of course, you'll be symptom free, no pain, bleeding will be okay and all of that. But the moment you go off it, then of course there's also another option, which is to use gonadotropin releasing hormone agonists, like drugs like Zoladex. It's very common. Most women actually know Zoladex, especially for women who are trying to shrink endometrial implants or even fibroids. Some people have used it, okay, to help them. So these drugs like Zoladex will, of course, prevent the secretion of the hormones from the brain, the reproductive hormones from the brain, FSH and LH. And so when you give this gonadotropin, you give this GnRH agonist like Zoladex, it prevents the secretion of that hormone from the brain, and as a result, it will help the woman to remain symptom-free. Okay, and usually you take these injections for between 3 to 6 months, and the moment you go off of it, their effect can still be a little bit lasting. Okay, it can still be present in the woman, but only for a small period of time, after which everything restarts again, and of course she starts seeing having symptoms again. So most of these medications, medicamental treatments, they are usually temporary. Okay, they are temporary and they are temporary treatments. So, but to give a long-lasting treatment, of course, the woman would have to do surgery. Where she has to surgery where they would clear out some of these implants from those sites where they are present. Imagine a woman having implant present in some of these ligaments, okay, that are holding the womb in place. Some of these implants, of course, would cause the woman to have pains, lower back pain, whether she's seeing menses or not. Because of the presence of these implants, she'll be having pain. So surgeries will help to clear these out. But the surgeries are usually laparoscopic surgeries. Because the moment you start doing an open surgery for such a woman, you are predisposing her to having adhesions. I spoke about sometime last year. So you don't want to do that, because endometriosis in itself is a pro-inflammatory condition. It causes a lot of inflammation and will make adhesions to happen faster than in any other person. So these are some of these precautions that have to be taking place. And like I said, to make the woman symptom-free for life generally is to actually remove the womb. It is usually the only way out of this. But you will now have to dabble with certain factors like, is this woman still desirous of a child? Is she still within the reproductive age? So these are some of these decisions that have to be made. Hello, are you there?
Yes, I am. Thank you so much, Doctor. This is where we draw the curtains for today. Our time is fast spent already. Thank you so much for being a part of the program today.
All right, thank you.
All right, thank you too. Right. Have a great day and enjoy the rest of the week.
I wish you the same.
All right.
All right, bye-bye.
Bye. Thank you so much for staying with us right here on Women Radio WFM 91.7. Join us again tomorrow for the program Radio Doctor on General Health. Today on Women's Health is been supported by ACT Foundation. My name is Rose Yusuf Kaiser. Do stay tuned to Women Radio WFM 91.7.
Mr. Johnson, I'm here for my money.
Baba landlord, I'm very sorry. My wife is very sick and I have spent all the money I have.
I've been telling you to ensure the health of you and your family with a reliable HMO.
Reliable HMO? Which of them can I go for?
Ives Medicare HMO Limited. They are one of the accredited health maintenance organizations with thousands of quality and accredited healthcare providers nationwide on their network. They have corporate plan, retail plan, student plan, and even community-based health plan. More so, their premium is pocket friendly.
Please, where are they located?
Their office is located at number 2 Osho Street, Okpebi Link Bridge, off Okpebi Road, Ikeja, Lagos. Their phone number is 08093 555 863 or 0803263 9058. Their website is www.ivesmedicare.com. Ives Medicare, health protection in your colors.
Ní Women Radio 91.7 àmọ̀rírì rẹ̀ bẹ́ẹ̀ ni a sì ń fẹ́ láti súnmọ́ ẹ sí ní báyìí ọmọ ẹgbẹ́ Women Radio yóò mú ẹ darapọ̀ pẹ̀lú àwọn akẹgbẹ́ obìnrin bíi tiẹ̀ ní ìjọba ìbílẹ̀ 36 ní Nàìjíríà. Ṣé oníṣòwò ni ẹ́, oníṣòwò aládàáni, akẹ́kọ̀ọ́ nílé ìwé, òṣìṣẹ́ fẹ̀yìntì, ìyàwó ilé tàbí àgbẹ̀? Women Radio wà fún yín láì ná yín ní ohunkóhun. Forúkọ sílẹ̀ ní wfm917.com. O sì tún lè darapọ̀ mọ́ ọmọ ẹgbẹ́ Women Radio ní Facebook group gẹ́gẹ́ bí ọmọ ẹgbẹ́. A ó bá ọ ṣe ìgbélárugẹ okòwò rẹ ní Women Radio tí wàá sì tún láǹfààní láti máa jẹ ẹ̀bùn tó jọjú lóṣooṣù. Dáúnlóòdù mobile app wa kó o sì máa gbọ́ wa níbikíbi tó o bá wà. Ọmọ ẹgbẹ́ Women Radio yóò mú ẹ ní àjọṣepọ̀ pẹ̀lú akẹgbẹ́ obìnrin bíi tiẹ̀ tó kù.
How long will it take you to confirm payment? I have been waiting for the past 1 hour. I'm so sorry. Our network is slow. I will just run out of data. Same excuse yesterday. It is unacceptable, please. You better switch to One Data Internet Service. One Data? Yes, One Data. One Data is an internet service provider with the best alternative and solution for unlimited speed. One Data provides fast and reliable internet service to organizations, homes, and places of interest in Nigeria with one
WFM 91.7.